afternoon. We are very, very happy that you are giving us this opportunity this afternoon to be able to share our vision for CNRC. We want the county home to be very successful when it comes to managed care. And the only way we can be successful with managed care is for us to be able to sit down and analyze what's going on in the healthcare industry. And then strategize to position ourselves where we can be successful, both long-term and short-term.
They'd like to get Jen and try to get it up and running.
Oh, okay. Yeah, take a breather. Otherwise, you're gonna feel like you have to keep talking until it comes on. And you'll have given the whole presentation and then have to give it over.
Searching for signal, it says. Searching for
You got
signal.
any jokes?
No.
Are there any nursing homes?
Seems like we're a puppy, I mean,
Well,
Life was much easier when we had airports, you know. Remember those? Remember those, Larry?
I remember being punished and having.
Yeah.
Yeah, sure.
I remember staying after a couple of times to wash and clean the
Yeah.
black.
A couple times.
Yeah.
He had a high rate of recidivism.
Like today stands and they reported to the IRS employee.
I think the Department of Labor investigation figured it was a
Child labor.
Oh, my God.
Yeah, I had one teacher, I never got hit, but I had one teacher who threw the eraser around the room, you know, people weren't paying attention, go, hit him on the head.
Could you do that today?
Corporal punishment was not unusual, especially if you went to Catholic school. All those nuns who did with murder.
Mr. Zalasko had a paddle that was like this long, with like the holes in it.
It doesn't look that long or small.
That was in sixth grade. And he used to just stick it up in front of the class and help keep everybody in order.
In sixth grade.
Mr. Zalasko.
It's just a Mary Regina. Yeah, look. Yeah, look on her.
I had a sister, Regina, not Mary Regina. Her nickname was Heather. I'm sorry.
She was not even German.
She was mean. She probably watching on YouTube right now. So,
Let's all look at the IMTO guide. Why isn't it working? There you go. Well, lucky for you.
we asked.
I'll teach you to volunteer for this duty ever again. There we go.
good thing because I was just about to pull up some jokes.
Oh, God. That would be something. Okay. Thanks, Jen.
Thank you. So this managed care coming, CNRC, we are at the decision point. Are we going to focus or are we going to diversify? So the states, financing for skilled nursing facilities is entering a significantly new era dominated by managed care in 2019. Key questions. Is this new environment compatible with CNRC's mission? Is this our purpose? Or are we better served by private providers? Can we succeed in this new environment? And if not, should we diversify to survive without managed care? And in doing so, do we remain true to our mission? So here is our proposition. CNRC's mission requires an ongoing commitment to long-term care and rehab services at the highest level of quality for all persons regardless of their payment source. And yes, we can succeed in a managed care dominated market, but we need a clear strategy, and changes to current practices is required. No, diversifying away from CNRC's mission simply to survive financially deviates from the mission and can be better done by private providers. So here's a changing landscape in the healthcare industry. Everything is going to be
Did Commissioner Eichelberger sign the waiver on that photo thing?
So the changing landscape is all about managed care organizations. What do we do with them? What are they there for? So we need to understand what managed care is. We need to strategize, because that will be our key to be successful in this business. Strategy for success: in order to maintain financial sustainability in the future, we need to understand the changing landscape. The state and federal government, they are focusing on cost and quality of care. So quality of care, we already have it. We have a very high quality of care. Cost reduction, we can do that. In order to be successful in the future, we have to do more than provide quality care. We have to understand our strengths and weaknesses and how we measure up in comparison to the surrounding facilities. What we need to do is do a market analysis. Like if this is CRMC and CRMC is sending patients to other nursing homes, what does he have that we don't have? What are his capabilities that maybe we have that maybe CRMC doesn't know that we can handle these patients? And we need to establish a continuum of care partnerships to assist in the overall improvement of quality of care, which will benefit our residents. Because if we're going to think about it, why do we have a nursing home? It's because of our residents. That is what we are here for. Some time ago, under the direction of Mr. Thomas, we had a SWOT analysis. So we have identified our strengths, our weaknesses, opportunities, and threats. So strengths, quality of care, which is very evident with our quality measures. Because if we're going to think about it, quality measures is actually part of our 5-star rating. And we have a perfect 5 for quality measures. We have experienced staff dedication. As an evidence to that, we have Ms. Barkley here, who has been at CNRC for
30 years.
30 years.
She started when she was very, very young,
Very young.
10.
We have the support of our commissioners. We have transitions proof of the commissioner's support. We are in the black. There is no general fund money that is being utilized. We have a good standing in the community. Dr. Lupinacci is very, very involved with us. He is with U.S. Physiatry. We have Alert Pharmacy. Alert Pharmacy is a very good resource for us, because what they actually do when it comes to our discharges, they actually send a packet of medications for 30 days. Now that is a very effective way to make sure that our residents, when they discharge the community, they don't go back to the hospital. Because one of the things that will usually be forgotten when you go home? Medications. Because it's either you can get an office visit with your primary care physician, or you don't have the medications that you have been discharged with. We have our long-term MA population. That is our strength. We have transitions rehab potential money, our 3-year marketing plan, union concessions supporting the past, new provider agreements. We have ICP, this is our Internets of Central PA, Pinnacle, Humana. Meeting with nurse from Pinnacle, we are actually a preferred provider for the joint and functional pathways that addresses our Medicare need. Our weaknesses, it's our recruiting and retention, our tower building coming to end of useful life, population, mostly MA, but if we're going to think about it, we may look at it as a weakness right now, our population mostly MA, but when we go to this new payment scheme, that population can be a big source of revenue for us. Current corporation of physicians, there is no affiliations. They are not connected in the hospitals. Most of them are retired. So we are not getting any referrals. County home image, current marketing media activities, lack of experience with managed care, limitations of our data and using it, management team turnover, questions about rehab operations, and long-term staff slow to change. Here are our opportunities. Working partnership with home health agencies and hospitals. Working partnerships, we are currently working with Holy Spirit Geisinger system right now. May 14, one of their nurses and 2 social workers are coming over because we want to forge partnerships with them. And then in June, Dr. Torsha, the medical director of Holy Spirit, with Dr. Siruji is coming over so that we can talk more on them providing us with hospitalists. And that I will go into details on how that will be a very focal point in the partnership that we are going to create with the other health agencies in the community. We have increased advertising of quality services, optimum rehab services. We are actually the only skilled nursing facility in town that provides 7 days of rehab, which is very good. And we are the only nursing facility in town that has a dedicated rehab unit that is not integrated into the rest of the skilled population. Demographics, CMI potential. This is really a big opportunity when we are going to be converting to the new payment system. 501c3 program, our outpatient rehab, and our Geisinger partnership. This Geisinger partnership, this is Holy Spirit. So it is already in the works. Our threats, the staffing challenge, the high staff turnover, the union promoting absenteeism, increased regulations with CMS and DOH requirements, it's just like our FSES, cost of doing business, financial failure, Board of Commissioners fall off in support, highly competitive marketplace, which it is probably a threat, but a highly competitive marketplace will actually make us deliver more, will actually make us better performers, knowing that there are other people out there that are doing the same thing. Potential drop in the star rating, which is very fluid, shut out by managed care, maintain flow of skilled Medicare and private pay admissions and other nursing homes in the county. So this is what we have envisioned. CNRC, a continuum of care through collaboration and partnerships. CNRC and managed care. The funding models are all changing to managed care. Even with the long-term residents, our payment system will be coming from MCOs. There are actually 3 MCOs out there right now who will be managing our long-term care residents. CNRC provides high-quality care and can successfully integrate into the managed care models. But we need to do a better job of benchmarking and communication of those benchmarks to our providers. Before we came to this meeting, we actually met with Kim Suda. She's a representative from Highmark. And she said, our scorecard, we are actually number 7 in the whole state. So once the scorecards will be ready, we are going to present that to you, but I'm actually very happy that part of the component is our cost. She said in that scorecard, we will be able to see how much dollars it costs us to take care of a rehab resident. With that being said, that is a very good tool for us to be able to go to the hospitals, our partnering hospitals, and tell them we have quality care, but we are very, very cost effective. And that's one of the things that will make you partner with us.
You know, if Highmark says so, it must be true.
Well, I mean, just so I understand this, is Highmark then as one of the MCOs or?
It is
a
a Medicare Advantage plan. But it is a Medicare Advantage plan, however, at this point in time, their thought process and all the benchmarking will be with the same thing that other MCOs will be looking into. So if we are already performing with Blue Cross, like for example, our length of stay, we're going to talk about short term. With a short-term population, the hospitals, like if he's the hospital, he will tell me, John, I only want 10 days for Jennifer to stay in your building.
And I think the point is that the MCOs will be looking at the same measurements. and
Measurements.
metrics that Highmark is.
So this is a good early indication of
Yes.
where
That
we
is
line up,
correct.
and that sounds pretty good if we're number 7 in this.
That's 7 out of 169.
169.
Now, it's a small population of residents, but it's better than being 165th.
Yes. And what she's actually alluding to after the discussion, because she was asking us about our performance, she was like, okay, so you are performing. She says, I may send some referrals to you. Because they want to see, they are actually looking at a different payment structure. Highmark wants to pay facilities that are outstanding performers a higher rate. If we don't perform much, then they're going to pay us with a lower rate.
Now,
So
is this, are we talking rehab, Medicare rehab?
yes,
Okay, so this is just a rehab unit, it's not the overall,
yes, this is just a
Short term.
rehab unit,
Okay.
the short term.
okay.
So-
Well, that's good, that's really good to know, though.
Mhm. So with her saying that, she says we are in a very, very sweet spot right now, and she wants to see us even go further and be up there.
Just one quick point. This relationship with Highmark and with Ms. Suda is a recent vintage. A year ago, it didn't exist. We engaged her and Highmark, and now they are engaging us because they see, and this was not done by accident. This was done mostly on the basis of our medical staff reaching out to them and trying to create this relationship. So,
Yeah, they were surprised. She said she was surprised that we were so high in it. And not that she doubted us, but just that with our size of the facility, we were so far up in the 90s. So yeah, they want to partner with us more than the other ones in the area.
but the point being, we went out and developed this relationship
Yes.
as part of the strategy to position ourselves from it.
Right.
Exactly. We invited her over and asked her what does she want from us so that we can deliver. Long term, we believe that in order to prepare, we have to implement strategies and immediate goals and short-term strategies. Long-term success is implementing and analyzing the changing environment and having a strong management team that works together in achieving long-term goals. So this is a continuum of care. What cost-conscious MC payers demand? So from the hospital stay, the patient goes to skilled stay. So they come to us. From the skilled stay, they go to home health. They rehabilitate there. What the hospital would like to see is that the resident from here, they don't want to see the resident bounce back to them. That is the readmission. Because that means to say we are not focused on resident care. Now, what they would also like to see with this skilled stay is a lesser length of stay. So probably 10 days. Right now, we're doing 15, which according to Kim is very good. 15, 14 days. If we can reduce that without sacrificing our resident quality, that is awesome. So skilled stay is lower length of stay. Now, why is home health partnership very important? It is very important because they are the ones who are keeping our residents healthy in the community. They are the ones who are going to be communicating with us how the resident is performing. The key element there is, if I'm home health and Jen is CNRC, and I have Cindy as a resident, I will call Jen, I'll tell Jen, Cindy is not performing very well, Jen. She's on 10 days, 15 days. Do you think you can take her back? So if this is a failed discharge from home health, the resident can go back to us. We are going to readmit the resident, bypassing the hospital. And that addresses their readmission, because remember, the hospitals don't want any readmissions. 30, 60-day, 90-day readmissions, they don't want that. So if we can partner with a good home health agency and keep that between the both of us, that is the goal there.
Just as a matter of a concrete example here. So I just went this through in 2016 situation with my mother and her failing health. Just to give you an idea of what the cost differential is. The CMS through New York State Medicaid, two things. First, it would allow my mother to sell her assets or transfer her assets to her sons in order to qualify for Medicaid with a 5-year look-back period. And secondly, when her health began to fail seriously, they were willing to provide 24/7, round-the-clock, 7-day a week, home care in the home, rather than have her come to a nursing home. Now, that also happened to coincide with my mother's wishes, so it worked out well. But from a strictly business standpoint, there's a huge gap that any payer is going to want to keep a person where it is least expensive to provide appropriate and adequate care.
That's true.
And then also with that, the partnering with the home health agency, like Holy Spirit has their own home health service. So then if they do go to our facility, we can't make them choose Holy Spirit, but obviously we keep them in the same medical loop if they would go with home health and Holy Spirit. And then that's going to be a positive Holy Spirit thing for us.
So that's the continuum of care. So key elements in the continuum of care strategy. So we need strategic alliances with referring hospitals and physicians affiliated with hospitals. That is what we are trying to do right now with Holy Spirit Geisinger. We are also going to be penetrating CRMC because they are going to be Pinnacle. These are two big organizations that if we are able to partner and they will be able to see our value, we will be able to get all the referrals. We need strategic alliance with home health care providers. Now looking at this, Holy Spirit actually has their own home health. So this is what's going to happen. We partner with Holy Spirit. They send us their patients. They send us their hospitalists. The hospitalist is in the nursing home looking at the patients every day. With a hospitalist, with a doctor looking at the patients every day, that reduces readmissions. Because if there is a complication, the doctor will be able to address the complication right away without sending them back to Holy Spirit. Then we partner with their home health. And actually their home health, prior to an example is an elective hip or knee surgery, they have prehab. So prehab is if Jen wants to do surgery, she goes to Holy Spirit for the surgery. Holy Spirit has a prehab somebody from that rehab group will go to Jen's house and take a look at whether she will be able to make it at home or not. What are the different adaptive things or modalities that needs to be done before she goes home? So it's all within one continuum. And that's what we are trying to promote with the partnership. And we are ensuring measurable quality, cost efficiency throughout the continuum. So this is our funding sources. Long-term, because CNRC, we have long-term residents and we have short-term residents. Short-term residents is our rehab. For long-term, we are getting it from Medicaid, and plus we have the IGT. The idea of IGT is to supplement the Medicaid funding that we're getting because it's not really that substantial. We have commercial, we have Medicare B, we have the MDOI, we have VA and private pay. For short term, this is now our rehab. We have Medicare A, we have managed care, and we have VA. So what is our immediate goal? What do we need to achieve at present? So looking at again, long-term and short-term. What do we need to do for our long-term? Long-term, we need to increase our census through case management. We need to increase our Medicare B through grand rounds. Improve quality of care measures and benchmarking tools. Now we go to our short-term rehab. What do we need to do? What is our goal? We increase census through case management. So if we're going to take a look at the common denominator, it's case management. So technically, to be successful, we need a good case management team.
Just so everybody knows, case management is what Lisa was doing. Lisa's funds.
Okay. We have to make case management robust. So what we are proposing as a structure in that case management team, we need 2 RN case managers, and it has to be RNs for the primary reason that the assessment is there. The RN can assess, can take a look at the resident, take a look at our capabilities, because we don't want a non-medical staff as a case management person, because the non-medical staff will say, well, maybe we can take that resident, but actually no. We cannot, because we are not equipped to be able to handle that resident. So 2 RN case managers. The first RN case manager, that is for intake. This is our business development RN case manager. Business development RN case manager, so she develops a market analysis, takes a look at the different hospitals, takes a look at the different facilities. What makes us different? What are the things that we can offer? And then she develops those partnerships. So she markets, she establishes collaboration within the hospital system. We maintain our presence in the hospital because that is the key, maintaining presence. Because if we don't have the presence, then they forget us. And she gathers admissions and referrals. Now, we have to be in the hospitals and doctors' offices, getting the admissions and making our presence known in the community. Then we have the RN case manager for outcome management. So what is outcome management? She follows up with the admission. She looks at appropriate room placement. Is this a short-term resident, or is this resident going to be long-term? So that there is not a lot of transferring the resident from one room to the other. Remain in constant communication with the family to boost customer satisfaction, because that is one of the things that will either make us or destroy us, the families. Because if we don't harness that customer satisfaction, they will just walk away and say, I'm not going back there. It's very poor customer service. Develop initial discharge planning upon admission. She needs to coordinate with the home health to get them ready to go back to the community. The first day the resident is admitted, I'm going to call Cindy, home health. Cindy, I have Jennifer here. Her goal is, she lives by herself at home, she's on oxygen. This is what you need to prepare. Is there something that you can do for Jen? She needs to monitor resident outcomes, the critical component of marketing and contracting in a managed care environment, and detection of changes in the outcomes.
I'll tell you what. I'll do that. You see if you can get that hand thing. I'll see if I can. I'll be your van. It's a scary thing. All right, IT. Need some help. Here, come in out there. Come in out there.
Is it locked up?
Froze up, I think. Stuff out tomorrow.
Yeah, this thing is moving. Try it out. There you go. Thanks. Well, I don't want to do it, aren't you?
So more focus and quality. So this is again the RN manager for outcome management. She coordinates with the hospital, coordinates with us, and home health. Because we want to make sure that the resident has a very successful discharge. Do follow-up calls on a daily basis. This is what all the MCOs will be looking into. Do you have somebody who calls them whenever they're in the community? How many times a day do you call them? How many days a week? And then we are going to satisfy that. Coordinate with the readmission process between home health and CNRC if in case it becomes a failed discharge in the community without bothering the hospital. Short-term essential change. Our physician management and practice models, it has to change. Current physicians, they are not currently connected with any referral sources. Their resident base or their cases are in CRNC. So they are not with Hershey Med anymore, they are not with Holy Spirit. So we are not getting any referrals from our current physicians. So we have to replace current physician model with referral partner defined model. Referral and payer physicians must be able to follow patients into CNRC and continue overseeing their care.
Just without impinging on anybody's integrity, if you look at it, I think there was a moment of truth when we all know these discussions with Geisinger have been going on for a long time. When the Geisinger people talked to Dr. Wallace.
Dr. Wallace.
Yeah, I mean, Dr. Wallace said, and I don't mean this in any way negatively, but he said, well, we want you to refer patients, but we don't want you coming in here and monitoring and following up or following through with the patients in here. And if you look at it, it's a perfect setup for an unaffiliated physician. We basically are there, we bring all the patients together, they come in, treat our patients, don't add to the patients, and bill Medicare and Medicaid, okay? What has to change, this is a big, big change. If we change that structure, that whole business model, and via the partnerships with the combination payers, payer organizations, their physicians will actually, by letting them in and treat the patients, our residents, then they also bring in referrals along with it. So that's a big thing that has to change. We basically have been providing a defended perimeter for our current physicians, keeping everybody else out, and they get all the benefit. You get a captive marketplace of people to service, and then they get to pay bill Medicare and Medicaid for that, but they don't add to the overall financial health or strategic objectives of the facility. Doesn't make them bad people. It's a very, they provide good care, there's no question about that. But if we want to adapt to the new reality, this has got to change.
Yes. So in this structure, we have the medical director there, PCPs, PCPs, that would be Dr. Wellman, Dr. Harm, and Dr. Gaulis himself. Now, this other side, this other component, we have internists of Central PA. Now, they are not giving us any referral sources, but they will come in handy whenever we partner with CRMC, which will become Pinnacle. Because here's CRMC. CRMC don't have any hospitalists. So who will be their hospitalist? Our ICP, taking care of the residents every day. And then we're going to partner with a home health agency for CRMC. So the residents coming from CRMC go to the ICP, which drive the cost of care low, quality outcomes, goes to home health, successful discharge. Holy Spirit Geisinger. We partner with Holy Spirit Geisinger. Now this time, when we partner with Holy Spirit Geisinger, they are providing us with their own hospitalists. That's why we need to open our doors to these hospitalists. I have the hospitalists here. We partner with our own home health agency. We partner with our own rehab. So Holy Spirit, their own hospitalists here in with us, CNRC, and then their home health. So there is a pathway for the resident. There is a clear path. And there is a clear direction. If something goes wrong here in the community, comes back to us, we admit them. They don't go back to the hospital. So that is quality of care. We are monitoring outcomes that's driving the cost down, which is, if we're going to go to managed care, that is what they want to see. Quality care, better resident outcomes, lower costs, which we can do it. The most important part here is therapy. Now, therapy is the silent giant there. Our short-term rehab, therapy defines our short-term rehab. Because if we're going to think about this, how many nursing homes are in this, within the 5-mile radius, 25-mile radius? A lot, probably 10. Each nursing home has their own therapy department. So I'm going to say, why would I want to go to CNRC? What's terrific about your therapy?
7 days a week.
7 days a week. What else? What are our capabilities? Ever since we have embraced ACP, we have the Synchrony program. That is something that we can market for dysphagia, for stroke patients. What else? The different treatment modalities. We have a stroke program. We have a pulmonary program. And these are the things that all the managed care organizations are looking into. Because if I am managed care, I wouldn't be admitting my patient to you. You don't have anything to offer. That's going to create like 100 days of Medicare A. I want just 10 days. So I want a facility that has everything with quality outcomes. So that is where therapy plays a very, very big role. And when they rehabilitate and they have good outcomes, when they go to the community, what do they say? CNRC is wonderful. I was able to go home in 10 days. Therapy was beautiful. It was just beautiful. And that is what we need to do, because that is marketing through our customers. So this is our proposed approaches. This is the case management office structure. This office reports to the administrator. So under the administrator, he will manage the RN case manager 1, the RN case manager 2. The admissions coordinator, because we need to have an admissions coordinator. And this one, this marketing person, this is just traditional marketing. However, this one we can do without if our RN case manager 1, this is our business development RN. If she's phenomenal, she will do the job. So we may not need the marketing there. Now, these ones, they also coordinate with me because they need to ask me, are we capable of taking care of this resident or not? Because we don't want to take residents and then later on, we are not able to provide the quality of care that they need. Short-term immediate approach, it is critical to our long-term success. This is the keystone for building managed care. So these are our key messages to the market. CNRC is your pathway to home. That is for our short-term rehab. We are here to help in each step. And then for our long-term, CNRC, your home away from home where memories are built to last. So looking at this in a capsule, this is for short-term. The main focus is the resident. This is the hospital. Whenever they have an acute episode, they go to the hospital. Holy Spirit Geisinger, Pinnacle Health, CRMC. So after the hospital, they go, well, prior to hospitalization, if it's going to be a planned admission, we have the prehab there. It's like what I'm talking about regarding Holy Spirit, home health. Prehab, pre-assessment to set the stage for residents' return to home. Then we have the acute episode there. Then we are here, CNRC. We rehabilitate our residents. We work so that they can go back to home to their prior level of function. And if they are not able to, we have long-term. We can be their home. And here is home health again, with coordinating with us. And the reason why we have this structure is because we want a seamless transition. Seamless transition, that is what they want to see. From an acute care episode, it goes to CNRC, go home with home health. They maintain their health. If they can't go home, they need long-term, they stay with us. Partnership benefits, it boosts our admissions for both rehab and long-term. And it gets us ready for managed care organizations for long-term care in 2019 by creating benchmarks of care that will influence rate, payment setting, and establishing proven relationships in the continuum of care model. So that presentation is just to address our short term. So the key there for short term is case management, marketing, business development, and coming up with very good resident outcomes, driving the cost of care down, and we are there. We are in the game. Now, because we are already doing all these benchmarkings, this will get us ready for 2019. This is now about long-term. So we're going to shift now to the long-term residents. Right now, we're getting all of our payment from Medicaid. In 2019, the payment, the funding sources will not be directly from Medicaid. It will be from 3 different managed care organizations. So Medicaid funding, present, this is us. County homes, case mix index is not considered. Our rates are lower than non-county facilities, but the non-county facilities, their rates are set by the case mix index. When 2019 rolls in, all Medicaid will be paid through managed care organization. And these are the 3 managed care organizations for 2019. For us, because actually Southeastern is already starting the managed care. And then we are in that T, which is for 2019. So we have UPMC for you, we have the AmeriHealth and PA Health and Wellness. Those are the only 3 MCOs. So just to give us an idea of the differences of the payment system. Here we are, CNRC. If we are using the rate for the county, we are actually getting 210.08 a day. That is county MA rate. But if we're going to take a look at the non-public MA, CMI, if we're going to use that computation, we're actually going to be getting 216.32 instead of 210.
So this is really important, and I just want to pause here. Our high level of acuity is a liability under the current system. Our high acuity level, or high CMI, in the new system then becomes more of an asset.
Correct.
So here's where the philosophical, political, what is the mission? We talk about the philosophical and political mission of a county facility as compared to a private facility. This is where the key business hook comes in. As a county facility, we generally have a much higher CMI because we have patients with higher acuity, okay? Because that's our mission, okay? If you translate a mission into measurable things, it's reflected by our CMI, and that's generally the case with all county-owned facilities. Why? Because other facilities, particularly for-profit facilities, cherry pick. They want the healthiest people, and they want to keep the people with high costs away, okay? Now, something that has worked to our disadvantage can, in managed care, not only work to our advantage, but also become the way that we turn our mission into a strategy for financial sustainability. Only if we can really manage the care well.
That's right.
Because a high CMI is not licensed to just bill for everything on a fee-for-service basis. Okay, but it is within a defined pot of money that the MCOs are going to be using. It is a way to lay claim to a bigger share of that because you're effectively managing patients with more serious or higher levels of acuity.
So that defines case mix. CMI is our case mix index. Okay, so this is used in determining the allocation of resources to care for and treat the patients in the group. Okay, this is our CMI performance. This is how we were performing before. So this is a glimpse of how we are from 2012 up to present. If you are going to take a look, we have never gone beyond 1.0 from 2012 until 2016. Our CMI was very, very low. But if you will have noticed, we are now at 1.0. Actually, as of present, we are at 1.067. So what does that relate to us in terms financially? A higher CMI will bring in a higher profitability. This one we were never really achieving there because we were under another payment structure. We were paying for performance. But now that there is a probability that the MCOs might be looking at or defining payment structures and referencing with the CMI, this year is our defining year. We have to go up. We have to build that CMI so that when they say, okay, here is how we are going to pay you. And if they're going to take CMI into consideration, we are already there. So they will not say, oh, you just made your CMI go up like a quarter ago because what, you want a higher payment? So we have to make sure that we are constantly, slowly but steadily going up. Medicaid funding, so it's going to be similar to Medicare funding. Emphasis is on cost and quality. If we do not meet the criteria, we will not get the referrals. We must be a preferred provider. There is a grandfather clause. No resident will be asked to change facilities. So what they were actually going to do is they're going to be sending our residents letters to choose between the 3 organizations. And if the resident does not choose, then an MCO will be assigned to them. I'm talking of the long-term care residents now. So we must have high quality measures, staffing, quality of care, readmissions, our star rating. Regulations are still changing and being developed, but cost and quality measures will be the major negotiating factor related to rate setting. So this is, yes, sir.
Excuse me, Sean, and I don't mean to interrupt you, but how are the residents supposed to know which one of these three to pick as their
They have
MCO?
not spelled it out yet, but they said that they will be sending letters to the families and then make them pick whichever they want to choose.
I mean, I would assume there's gonna be some kind of, what, rating or something? I don't know how.
There'll be information provided, how much will depend on either what the law requires.
Mhm.
And you'd like to think there would be truth in advertising, that people would know what they're choosing. But that's up to CMIS to do that. Now, the managed care organization, if you join and, you know, you're asked to pick, if you go from a standard fee-for-service route from a PPO, you go to a managed care organization, you have to be assigned to a primary care physician. You can choose one, and if you don't, you're assigned one. And you
Yes.
can always change later if you don't like it. And what they do is the more progressive managed care organizations go out there and market their physicians. They'll tell you what school they went to, they'll tell you the years of practice, the subspecialties. Sometimes they'll even take patient feedback.
Well, we went to PAC a couple of weeks ago, we learned about this, we know it's been in the works, but we're luckily in the third,
Yeah.
that was going to be instituted,
Well,
right,
what
Philadelphia,
the
the
Eastern-
Pittsburgh area, are going to be
They're
instituted.
gonna blaze the trail here.
Yeah, so there's going to be a learning curve for them that will happen.
Okay, well, I just read here, and I don't want to get us off track from where we were, John, but I just, it says it was grandfather clause, no resident will be asked to change facilities so that
Yes.
anybody who's at Claremont will be able to stay.
Will be, yes.
But is this like, when they go to choose one of these three, then
Mhm.
they have that option, is this why all of the doctors who are seeing them, you know, they're gonna be in one of these three, and I would assume if you wanna keep seeing the same doctor, then what, you would have to pick one of these that has your doctor?
That's
Or is
what
that,
we're
I don't know,
taking.
maybe I'm simplifying it, maybe, I'm sure it's much more.
Hasn't
complex.
gone,
Can I insert a little bit too? The nursing home facilities will also be preferred providers to those three MCOs. So if you're not a preferred provider, that resident, if they would choose to come to our facility, they would be private pay.
Mhm.
And they have no way of paying, so they would not be coming to our facility. That's the importance of becoming a preferred provider. Is that
All right, so nobody's gonna get thrown out of
correct?
Claremont.
Nobody that's already there would have to.
They would have to pick
And there would
the
be
provider
something,
who, or all three of them, hopefully, that are in.
Mhm.
and there would be something worked out for those residents for payment models. But if new residents coming in, we would have to be, if they want to come to Claremont, we would have to be on the preferred provider list of one of the three.
Okay, we could be in all three, or we could be in
Yes.
two.
Yes.
Okay.
So this is our 2-year plan prior to the MCO initiation. So this addresses the long-term component. We maintain partnerships, maintaining or decreasing the length of stay, readmission rate reduction, seamless transition within the continuum of care, better resident outcomes, maintaining a good star rating through good survey performance. We have to show what we have right now, so that when the MCOs come rolling in, they know that they can partner with us and we can be in their network. We have to increase our case mix index. We're going to be performing grant rounds, which increases our Med-B participation. Increasing our case mix index might give CNRC the leverage to negotiate better rates from the 3 MCOs, because we will be negotiating rates with them. So bear in mind, they might be thinking about CMI. What would be the CMI equivalent with a non-county home rate? That's why we need to build that CMI up there. And case mix index is driven by long-term care population. So the bigger our long-term care population, the higher we can go with the case mix index.
So we do want to diversify and have the short term in there, but really, a lot of our success is based on maintaining the long-term care component
Component.
of the practice.
we actually have what we have right now is actually good. We have what we need. What we want to add is the case management, because that's the one that drives our admissions. We don't need to be a CCRC, because here, we'll just sit down and think about this. We have, other facilities have CCRCs, and if I am in that CCRC, like, for example, Church of God, they have their independent living, then I'm guaranteed that when I need skill, I go to my skill. That's the whole purpose of a CCRC. So where do we get our long-term? We need to go to our One West Penn. This is what we're here for. It's public service. One West Penn, two West Penn. What about the apartments near us? They're all subsidized. It's the geriatric population who's there. We need to reach out to them and do like blood pressure. We need to make our presence known. Because if we forge that bond with them, that relationship with them, the minute they go to the hospital, the hospital will be asking them which nursing, skilled nursing do you want to go to? Oh, don't worry about that. I already know where I want to go. I want to go to Claremont. They're there every month checking my blood pressure. I have a friend there. They have good nurses. That is our community service. We have all these assets. We need that business development to think where the need is. And if we just strategically know where the targets are, we will be able to get it. The presentation has focused largely on quality and the changing funding. In order to achieve this, it is important that the organization is moving in the same direction. We need to start monthly integrated management team meetings now and create long-term goals for the facility as a whole. And we need to create additional quality measures and risk assessments for other organizational attributes, like dietary, facilities, and activities. So this is our long-term goal. We continue to develop and maintain a good relationship with managed care organizations. We maintain better resident outcomes through quality care. We need to be the preferred provider within the area of network. We maintain high resident satisfaction, high partner provider satisfaction, and we continue to serve our community, maintain a stellar reputation, and become a center of excellence in short and long-term care delivery. So everything, we can do it. Everything that we have thought through, we really can, if we're given the opportunity to continue. So thank you very much for listening. These are the pearls that we have gathered through our PACA conference. We would like to thank you all for sending us to that conference, because that was an enlightenment for us all.
And it wasn't in Las Vegas.
Well, I want to thank you for getting this in front of us and getting us geared up for things that we need to do. So, and really what you're talking about is creating our own network, with a lot of other providers out there. I think that's going to be important. One of the things that you skipped over that I consider to be a strength is the fact that Claremont doesn't need to provide any investor income, like our for-profit nursing homes have to. Now, I know we have other pressures, but when you think of it, if we're on a level playing field, and we have the higher, acuity and the higher case mix, you would think that we should be able to survive, even if this, with this managed care market coming along. So, I know that the for-profit folks have been receiving some extra resources over the years, and hopefully that's gonna come to an end under all of this, right? So, again, if there's a level playing field, and as you said, John, I think is that the issue of trying to identify those folks who need care in Claremont. And so anyways, very interesting, and it is very complex, and I do think whatever we can do to establish partnerships with, whether it's Geising or Pinnacle, we don't know what's going to happen in Fairmont, or Carlisle yet, relative to Pinnacle, but it's good to establish those relationships. Thanks for your presentation.
May I say something? Okay. I just wanted to say, thanks for the opportunity to present, but as a long-term employee of Claremont, I've seen Claremont go through a lot over my time span there. Some good, some bad, the good outweighing the bad, and I'd like for it to stay in the community, because we do take in our residents in the community of Cumberland County, that we be careful with the higher acuity and things, and that's what has made us what we are today. And I think joining the partnership and things that will really help us to maintain what we are to be in the community.
I've only been here 4.5 years roughly, but I've moved 15 times in 33 years of marriage. But I have worked at a number of facilities. None other one had ever been a community-based facility like this that is a not-for-profit. And there is a difference. We do provide better care with cost containment, and we're making it in Vermont, and we want to continue doing that, and I'm proud to be part of it.
And Highmark thinks we're doing well.
And we need to talk to them. I could be on that liaison.
Yeah. Listen, thanks. Good job.
Thank you, that was excellent. Any other business to be brought from?
Yes, so I just had a question.
Yes.
What is next with this? And what's the next steps involved? This is a fine presentation, was raising a number of questions with me. And, assuming this is not the end of the process.
Oh, no. We tried to set this up, I mean, you had Bob's presentation.
Yeah.
And the emails that we all sent back, the whole issue of the mission, and now you have this as an alternative option or road to go down. I think we need some discussion, on that, facilitated discussion, how we guys want to do it.
Yeah.
Because these are, it requires a certain investment, and it requires some kind of agreement on what exactly our mission is, and what our mission, both in a positive way, what we're supposed to do, and in a sort of negative way, what are we not supposed to do in order that we don't be redundant with the private sector, or compete with the private sector in the neighbors.
Yeah, and that was, I remember that being it's one of the areas of focus in the previous conversation. I guess that's where I still have an information need here. We talked about the county mission somewhat today, but I'm not sure we really cracked that nut. And I think we may want to revisit some of our guidance in terms of that. What I heard today, and I don't propose to be an expert on this, but what I heard today was about the references to the county mission. You made several references to the addressing a very acuity level. I've not really heard that before in terms of county mission, as everything that we've been using for guidance in the past, maybe insufficient, but was that the county's responsibility is to provide for indigent care. And indigence and acuity may have some correlations, but they're not, one is not an accurate reflection necessarily of the other consistently. So I think I would like us to have a little bit more discussion on our responsibility for providing indigent care, as opposed to what appears to me still to be following this path that says we have to do all these things to remain competitive against all the other nursing homes. in order to provide for the indigent care. And I sometimes feel as if the indigent care role has been relegated to almost I hate to use the term sideshow because it has a negative connotation, but that it's been downplayed to an extent that we're now focused more on building an operation ostensibly to support indigent care, but we've got all these other things in the foreground, and indigent care is sort of moved to the background. And I guess this has raised a number of questions with me as to whether we've truly honed in on the county mission issue or whether we've not done so.
We have not. I mean, I've been here for almost 4 years, and I can't tell you what the mission of the CMRC is. I have bits and pieces. When you talk about indigent care, I think that has to be defined. Is indigent care homeless people on the street, or is it people on Medicaid?
Well, and this, I think, fundamentally goes to the whole issue of the public-owned facilities at this point is the instances of the nature of indigent care has evolved enormously. The resources available to combat the lack of indigent care has evolved. Medicaid did not exist when that role was first introduced. So, exactly. So maybe that's what's really missing here is a good analysis of what our responsibility remains and how we accomplish that, since the environment, the market environment, has evolved significantly beyond what it was when we were first charged with that mission. So I think that's a pretty fundamental discussion that maybe we need to have.
And I think that those emails that I sent that had some attachment about some background, we begin to touch on that to some extent.
Okay.
But we have to define it on our terms in this county.
Right. In not only in the changed environment that we've experienced over the past number of decades, but in the further changes that we're seeing now in indigent care. So I think we owe it to ourselves as we are at this sort of fork
I
of the
think
road. for us to-
that's a good discussion to have. I mean, my understanding is that we're required as a county home to take Medicaid from day one. We don't have the opportunity like some of the other facilities to cherry pick who it is that's going to come in the front
Other
door.
than people that are not equipped to
So-
handle from a strictly from a medical
Yeah.
standpoint.
But if we need to, further examine, the mission, that's fine. I think one of the initial things here that I'd like to know where we are and probably needs to be addressed in the short term is this question about the case managers and dealing with the rehab unit. Because I don't know where we are right now on that.
We have a
our,
single position that's vacant, and at one point, somebody downgraded it to an LPN. We put it back up to an RN, but at this point, it's still vacant. I don't know that
But your recommendation is for us to consider 2 RNs, is that what I understand?
Right, over some period of
I
time.
mean, we made a significant investment a couple of years ago in transitions, okay? So, I still believe in that goal of helping, or having transitions help us to, not only care for those people who are just leaving the hospital, but also to help financially, to help support the overall mission of Claremont. But again, I just think we need to address that in short order as to what's happening there, because we have this gap right now.
Yes, we do.
We're struggling right now trying to get admissions that are appropriate. We're internally looking at admission possibilities on paper. We do have our liaison going out, Helen represented us in marketing, and she's taking a PRN nurse who has retired from our facility, who's coming back, and she's going out periodically. She doesn't want to do this full time, but that's what she is doing, to represent us as a professional out there. But we need to get those hired. That is very big thing in maintaining, because it's being a struggle trying to get our census to come up. So that has to be really addressed quickly.
So I think there is some significant follow-up, and we will be in touch very shortly with some options for you to consider.
Thank you. Is there a motion for adjournment? Thank you.
Thank you.
We have the thing that.
C2,